Our first endocrine disorder that we're going to look at is a pituitary gland disorder, which is growth hormone deficiency. Growth hormone deficiency is just simply they're not making enough growth hormone. And when you think about a child who has growth hormone deficiency, they're not going to grow to their full potential size. So without treatment, most children will only reach about 3 to 4 feet in height. And you can see kind of a comparison, like a child who has growth hormone deficiency versus a child who has appropriate amount of growth hormone. In this one picture graphic, the difference in the height and just kind of the structure of the body itself, to give you a little bit of an idea. Always important, though, to think about what are reasons that they would be lacking growth hormone and why they're deficient in it. You want to look for other causes. Are there structural issues like a tumor? Was there trauma? Just a structural defect? Is there a genetic origin? We're always looking for what is the root cause of why we are deficient in growth hormone. When you think about their assessment, for the most part, starting out as a newborn infant, and in the first couple years or first few years of life, they have normal size, normal weight and weight at birth. Usually within the first 3 years, first few years, they start to fall below the third percentile for height and weight on those growth charts. Again, why it's so important to maintain those growth charts so that we can catch this early. Some things that you'll see appearance-wise, their mandible tends to be more recessed and immature. The nose is smaller, teeth are crowded, voice might be high-pitched. They'll have delayed epiphyseal closure as well in the long bones, but it's proportional to their height delay. So when we look at diagnosis, we look at their history, we look at their physical findings. We can certainly do some blood work. But when you talk about their history, we want to look at what is the family's history for having short stature. Is there that genetic origin? You want to look at prenatal and birth history for any suggestions of intrauterine growth restriction. You want to assess, was there any sort of severe head trauma that could have potentially injured what gland? You got to think about, where does growth hormone, where is it produced? And that we're talking about the pituitary gland for your blank. Do they have a chronic illness that's affecting their growth? There's lots of illnesses out there, whether it be metabolic, whether it be a cardiac defect that's affecting the way that they grow. So again, you're just looking for other possible causes that you can rule those out that would contribute to their decreased level of growth. Maybe you want to do a 24-hour nutrition history. Are they just simply a picky eater, which is affecting their growth enough that they're not growing like they should and maintaining their growth? Depending on the age of the child when this is first identified, we want to assess what's their feelings about their height and feeling short compared to their peers. When you look at physical findings, there's lots of things we can look at. One of the biggest, or a couple of the biggest ones we're going to do, is looking at their wrist x-rays. We look at their wrist x-rays because that is going to allow us to look at those epiphyseal plates and looking at epiphyseal closure of the long bones. It is when you have a growth hormone deficiency, you have a delay in those epiphyseal closures. And that, again, the epiphyseal plates correlate with what their height is. So if we're lacking growth hormone, then you're going to see delayed epiphyseal closures. So growth hormone deficiency is proportional to the height delay. We can also do CT, MRI, ultrasound, basically imaging studies, and that's going to help identify if there is a tumor or a structural issue that's affecting the pituitary gland. Blood work-wise, we can evaluate how much growth hormone is circulating. So usually we're going to see a decreased level of growth hormone circulating. And again, we're just trying to rule out pituitary tumor, other reasons why the growth hormone production may be decreased. Again, going back to those wrist x-rays, so we can look at those, and those are also, as a marker in the beginning to help identify that delay in the height and the closure of the epiphyseal plates, but we also use those as a way to monitor or determine when our course of treatment should end. So it's not like that's the only time that we get it, but it is certainly one of them. Let's talk about therapeutic management for growth hormone deficiency. Well, let's make it simple. If you're lacking growth hormone, what do you think you should give them? Growth hormone, right? So basically what we use is something called somatropin. Brand names would be Nutropin or the Humatrope. They are considered long-term treatment for children who have growth failure. When we give growth hormone, it is usually administered daily by IM injection, so you're being administered daily. And when's the best time to give growth hormone? Like, what time of day do you think? Well, best time to give it is actually at bedtime. Why at bedtime? Because when it gets taken up during a particular cycle, sleep cycle, it's true, children grow when they're sleeping. And we're trying to hit that optimum time that they're going to get the most uptake from the dosing. So optimum dosing is achieved when it's administered at bedtime. And then how long do we do growth hormone? How long do we determine that they need to be taking these daily injections? Well, growth hormone is usually continued until bone maturation takes place. How do we know when bone maturation takes place? Going to do those wrist x-rays and look at the radiologic evidence of the epiphyseal closures. That's when we determine when it's an appropriate time to stop growth hormone. Once we know that they're fully grown, those epiphyseal plates are closed, then we can stop doing growth hormone injections. Recommend looking at that box 48.3 and looking at the pharmacology responsibility for somatropin as well, to just kind of be more familiar with the growth hormone itself. Right, the next endocrine disorder we're going to talk about, or endocrine dysfunction, is the pancreas disorders. Obviously, the big one we're going to talk about, type 1 diabetes mellitus. It is an absolute or relative deficiency of insulin. You've talked about type 1 before, right? In other courses. But when does type 1 typically start? Usually they're diagnosed as a child, right? And this is a lifelong disease to live with. So again, it's that absolute or relative deficiency of insulin. It's due to the body's inability to produce or use insulin. They have equal incidence between males and females. About 1 out of every 500 children or adolescents are affected with type 1. And it results from an immunologic damage to the islet cells in the susceptible individuals. Why we have this autoimmune destruction of islet cells is unknown. So pathophysiology, again, the deficiency of insulin. So with the deficiency of insulin, glucose is unable to enter the cell and it remains in the blood, which causes your hyperglycemia. I realize I have a typo there. Hyperglycemia. When the serum glucose exceeds the renal threshold, then the glucose spills into the urine, which is your glycosuria, which then we're going to see accompanied by a large loss of fluid, your polyuria, which triggers your thirst response, your polydipsia. The cells break down protein and fat for a source of energy, because if it's not getting it where it needs it, it's going to find it elsewhere in the body, right? If we left type 1 untreated in children, or goes unnoticed for quite some time, typically what you'll see in an untreated child is some weight loss. They can become acidotic because of the buildup of the ketones in the blood. They're going to have dehydration from all the water loss from the polyuria, which then they'll also get into electrolyte imbalance and getting in especially loss of potassium and phosphate in urine. And of course, they're going to lack the necessary components for growth. So they're going to remain short in stature and underweight. Right? Which, when you think about the untreated child, we've got hyperglycemia, dehydration, acidotic buildup in the of ketones in the blood, electrolyte imbalance. What does that tell you? What are we getting into? What's a complication of type 1? A serious complication. You should be thinking diabetic ketoacidosis. We'll talk about that later. But if you can understand, if they're left untreated and they can get into DKA, that's going to help you, because you're going to see these same things when we talk about DKA. All right, so assessment-wise, What's the onset of your symptoms typically like in a type 1 diabetic? Well, they're usually abrupt. They happen very quickly. And kids, sometimes, depending on the age of the child, parents often will notice when they look back and thinking about when maybe they started seeing some signs and symptoms, parents will often notice an increase in thirst and urination. It can even be recognized sometimes as bedwetting or enuresis in a previously toilet-trained child, someone who's achieved toilet training, has not had problems with bedwetting, all of a sudden starts bedwetting. Well, why? Again, it goes back to all the issues that are happening pathophysiology-wise, right, that we already talked about. And again, getting into these signs and symptoms that we're seeing. Dehydration. Dehydration, if we're losing too much fluid overall, you got to think about what it can affect other systems, right? So think of the GI system. Dehydration can actually lead to, what do you think, if we don't have enough fluid in our body and it's affecting GI, it can get into constipation. So sometimes the child has probably had some recent constipation issues. It's not normally a problem for them, right? Again, it's because of all that loss of the fluids in their body. So dehydration may cause constipation. As also part of our assessment, we start doing some laboratory studies. And of course that gets into also the diagnosis. So oftentimes what they're going to do is a random plasma glucose, and that level on the random is greater than 200. Then we don't take just that one. We look at doing some other tests. They can also do, and you don't have to memorize these numbers necessarily. A normal fasting range for a child is 70 to 110, and the non-fasting is 90 to 180. The big one to know is if their random plasma glucose is greater than 200. That's important to know. They test significant for glycosuria. That's important. The acceptable blood glucose ranges that I have for children with type 1, that little chart that shows before a meal, an hour after, 2 hours, and then between 2 and 4 a.m. You don't need to memorize those. I'm just trying to show you generally what they should look like when we're talking about acceptable blood glucose, but I'm not going to get that detailed when I ask questions. Getting into your diagnosis, which is further really getting into the various laboratory studies that we talked about. In order to be diagnosed, they need to have a fasting blood glucose test and a random blood glucose test to confirm diabetes. We don't just take one, because what if that one was a fluke, right? So diagnosis of diabetes is established if one of the 3 criteria are present on 2 separate occasions. So they have symptoms of diabetes plus a random plasma glucose that's greater than that 200 I talked about. That 200 is important. If they have a fasting, so 8-hour fasting, 8-hour blood glucose that's greater than 126. I know, odd number, but hopefully that number sticks out. So fasting blood glucose greater than 126. We could do a 2-hour plasma glucose. Again, greater than 200. The 2-hour plasma glucose, that's when they take the 75-gram oral glucose tolerance test. So they have to fast for 8 hours. They'll do their fasting blood glucose right before, drink the 75 grams of the oral glucose solution, and then they'll test their blood glucose level at 1 hour after drinking, and then at 2 hours after drinking that glucose solution, and see where they're at. So again, they have to have one of the 3 criteria on 2 different occasions. So looking at the symptoms, the fasting, and a 2-hour plasma glucose are the big ones we're going to look at. Or doing, again, plus the random glucose if they're just looking at symptoms. Other diagnostic tests that we might want to look at, white blood cell count. Why would a white blood cell count be present? Especially, or I shouldn't say present, but why would it often be elevated even when there's no infection present? Well, that's the response to the ketoacidosis that's occurring. Another important test that we look at, the glycosylated hemoglobin, or the HbA1c. For children, normal levels, somebody who doesn't have type 1, is between 1.8 to 4.0. A value that's greater than 6.0 reflects excessive level of serum glucose in children. And why do we look at HbA1c? Well, it's a good indicator of the child's average blood glucose over what time span. You should be thinking about the 3 to 4 months. So 120 days, or roughly the 3-4 month time span. It gives us that average of what the glucose has been running. May also need to look at serum potassium level. Well, why would we need to look at serum potassium level? That's not their problem. The problem is with their blood glucose, right? Well, if we are losing too much fluids and we're losing electrolytes, one of the big ones we're worried about is potassium. If we lose too much potassium and they're too low in their potassium level, we need to be looking at an ECG, or EKG, not ECG, sorry, EKG, because we're worried about what effects does it have on the heart. And they often have T-wave abnormalities that we would want to look at. And that tells us they have a potassium deficiency if they have T-wave abnormalities. All right, let's talk about therapeutic management for type 1. Our therapeutic management for type 1 diabetes, it is aimed at 5 measures. And those 5 measures are insulin administration, regulation of nutrition and exercise, stress management, blood glucose monitoring, and urine ketone monitoring. So when we look at insulin administration, initially the regulation of the insulin, when they're first diagnosed, they're usually hyperglycemic, and they can even be ketoacidotic, or getting into DKA, or could be in DKA. And we'll talk more about the specifics of the care and what to look for DKA in children as a complication here in just a little bit. But typically, one of the big ways that we manage a type 1 diabetic is insulin administration, right? There's all kinds of insulins out there, different types, whether you've got fast acting, intermediate acting, or long acting. Knowing your different types of insulin is important, not just in pediatrics. That's something that you should know, especially getting ready for NCLEX. That's a good thing to know. So knowing your different types of insulins, again, are they rapid, intermediate, or long acting? And then, of course, knowing what are their peak effects, what are the duration. Those are things that are really important to know that can help you. Doesn't matter, adult, child. Those are things to know. So I highly recommend looking at that in your various types of insulins. But when we talk about what works for one kid, obviously that's different from child to child. They can be regulated on all different varieties of insulin programs. Oftentimes they're usually given 2 doses per day, usually before breakfast and before dinner. They can have a combination of an intermediate acting and a regular insulin. There's all different methods of what works for that child. So just understand that, again, it can be dosage obviously is different for each child. What the regimen looks like, the number of injections per day is different for every child. Just understand, and I'm not going to go through all of it, it's just important to work around what is working for that child and what does and doesn't work. If you have 2 different types of insulins and they have different peak effects, you need to understand, obviously, again, that's why it's important to know the peak effect and duration, because knowing those, especially if they have, they're mixing insulins in one injection, you need to know what's going to start working when, how long it'll work for. The biggest reason you need to know it is because of the experience of hypoglycemia, and when to potentially expect that for a child. Important to definitely teach about injection techniques, where to inject, how to draw it up if they are mixing insulins, which one you draw up first, and that whole process. Again, appropriate injection sites, and rotating those injection sites, making sure if when they're doing the injection, is the child able to do it? Does parent still needs to monitor them even if a child is able to do it? But young children can start learning to do insulin injections at a young age. I mean, it varies on the child. There's not one set age, but even as early as 8. There's some who are younger than that who are managing, with the adult supervision, are managing, checking their blood glucose, and drawing up injections, or a lot of them have the little auto injectors to make it easier. They're not drawing up as much insulin out of vials as they used to, but there are still some who do, and just making sure they have the appropriate education that they need. You can see through the next, they're just pictures of some of the next slides about injection sites, and really just showing the various techniques, making sure how to check their blood glucose, how to give in insulin, where they can give it, are certainly important. That's not new information to you. But picking back up on page 5, if they've got an insulin pump, that's certainly something we're seeing more and more. They're about the size of an iPhone. They deliver insulin at a constant rate. Important certainly to make sure, any family or child who is getting an insulin pump, they know how to use it. They know when they need to, how often they need to change their sites, how to give bolus insulin in cases that may need, for times of exercise or nutrition reasons, when they need to adjust things. They'll learn how to do that as well. And we'll talk about nutrition here on the next part. Alright, so nutrition-wise, recommend looking at the box 48.7 about nutritional guidelines for children with type 1, just kind of as an overview. But typically we look at insulin to carbohydrate ratios. So parents, and depending on the age of the child, need to learn how to count their total carbohydrate intake for the various foods that they're eating in a meal, and calculate it individually depending on age and activity of that child as well. Overall meal pattern, typically 3 spaced out meals a day. They should be high fiber meals. They may need or will need a mid-morning, mid-afternoon, evening snack to keep the carbohydrate amounts as level as possible throughout the day, so we're not having these big spikes up and down. Parents oftentimes, at least in the beginning, and the child too, as long as they are developmentally age appropriate to do so, meet with a nutritionist to help them define what is a high fiber meal, become more adept at carbohydrate counting, and what meals and foods are best to serve to the type 1 diabetic child. And then we get into also the self blood glucose monitoring. Children as early as early school age, can learn to do, the finger pricks and using an AccuCheck monitor. By adolescence, for sure, they're usually counting carbohydrates independently, monitoring their serum glucose levels on a daily basis. That doesn't mean an adult shouldn't still be kind of overseeing or following through, but they can usually be pretty independent by that age. They can be taught how to dip their urine and do urine testing. It's not routinely used mostly to test for ketonuria, oftentimes, especially when the child might have like gastrointestinal, the flu, or some sort of illness where they're not able to eat, is when urine testing is really important to do. They can also have times of what's called a honeymoon period, which is oftentimes when they're first diagnosed, and we get their blood glucose levels regulated. Then they kind of go through this honeymoon period, which can follow. What ends up following is they need a smaller amount of insulin than what they've been taking, and sometimes they don't need any at all for glucose regulation. And what's happening is the exogenous insulin is stimulated the islet cells to produce a small amount of the natural insulin. However, the islet cells are going to begin to fail again anyway. The diabetic symptoms will occur. So sometimes parents feel like what we call this honeymoon period, oh, my child's getting better, we're cured, we're not going to need insulin. Well, it's kind of this false hope. They're still going to need it. It's just the body is reacting to what we're doing, and it tries to fix things on its own, but it's not going to work long term. So assure them that yes, they are still really diabetic. This is normal to go through, or warn them ahead of time that they might have this honeymoon period. It's just part of that education that needs to be done. As well as there's times that we need to have stress adjustment dosing. And that's oftentimes whenever they go under stressful situations, whether that be physically, emotionally, surgically, they have a procedure done, then they may have a need for increased amount of insulin in order to maintain their glucose level. And we'll talk about complications in the next part. I'm just going to briefly talk about complications, just in the sense of from illness, not getting into the big one or the most complex complication of DKA. I'll talk about that separately on another slide. But with complications that we can see with type 1, anytime an infection occurs where the child's temperature rises, it changes their insulin resistance. If they're sick, their insulin resistance, what does it do you think? It increases, right? So insulin resistance increases, which then leads to what kind of need for insulin? Do you think it's increased or decreased, or doesn't change at all? Well, if their insulin resistance increases, it leads to an increased need for insulin. It's definitely important to teach parents to notify their primary care provider, whenever the child is ill, and carefully observing for changes in insulin dosage if it's necessary, especially when it's a GI illness, like where there's nausea and they're vomiting, or diarrhea, or in cases that their temperature is prolonged. I'm not talking about as soon as it happens, but you worry about how long does it go on. Is it just, for a few hours of the day? Is it, if it's over 24 hours, the big thing, especially when it's GI, we're worried about dehydration, especially if they can't keep things down. That's a real problem, because it creates bigger issues as well. You can also see some of the long-term complications, especially as an adult, due to that chronic hyperglycemia, things that you've probably talked about before, the atherosclerosis. We can get into blindness because of the thickening of retinal capillaries, cataract formations as well. Like I said, I'll talk about DKA on another slide. Right, when we think about teaching patient education, there's a lot of things we need to teach about, not just to the parent, but also to our patient. One of the big ones is obviously self-administration of insulin. They say from about 8 years of age, children can be taught to administer their own insulin. I have seen some who are younger. I've seen some who are older before they learn how to do it themselves. But typically by 8, they can learn to administer their own insulin. Doesn't mean an adult doesn't still need to be supervising or kind of overseeing. Absolutely do. But the child can learn. They are capable. At least one adult in the family should be taught to give insulin as well, especially because there are days the child may refuse to administer their own, or they're just not feeling well, want somebody else to do it. Parents do often have sometimes a hard time giving an injection to a child, at least in the beginning. You need to teach them to just view it as it's a way that they are helping their child and alleviate their distress. So another thing we need to teach about exercise. That's not new information from probably what you've heard with the adult as well. We certainly know that exercise has its effects on the insulin, and definitely needing carbohydrates or getting into hyperglycemia versus hypoglycemia. Exercise is important, right? We encourage it. Just because a child has type 1 doesn't mean they can't exercise. So there's no type of exercise that is restricted. It's an important component because it helps you use up the carbohydrates. It helps reduce the chances of having hyperglycemia. The biggest problem is that especially as kids, they're active in this. If they're really into competitive sports and things like that, they can get into some very vigorous exercise. It doesn't always have to be sports related, but they can get into vigorous exercise. Which, if we get into vigorous exercise, then we can develop hypoglycemia. And that's just because it's due to the increased absorption of the insulin from the injection site and use of the glucose by the active body cells. So again, important to teaching about choosing an injection site. If they're going to be doing vigorous exercising, probably don't want to be injecting into their leg if they're going to be running around, right? Choose a different site that's going to be least likely to be exercised. They may need to eat additional carbohydrates or decrease their regular insulin injection according to a protocol before exercise. We want to teach children to design a daily exercise, a consistent daily exercise. So we still want them to get them up, get them moving. We just worry about if it's prolonged exercise or very vigorous exercise, or getting into hypoglycemia. So sometimes they need a snack or something to help kind of sustain their blood glucose levels, right? Or they might need a little bit of an adjustment in their dosage of insulin. Hygiene-wise, no different than what you've talked about. You can review that. Again, it's making sure we're doing good skincare, we're wearing properly fitted shoes, making sure letting things heal, tending to cuts and scrapes, and cleaning those properly. For girls, we want to make sure they're having good perineal care. We want to prevent vaginal infections and such. Right? Let's talk about, we'll talk about hypoglycemia management in the next part. Alright, so for teaching about hypoglycemic management, that's probably the biggest issue that we usually see is hypoglycemia in children. Once they've been established and we've gotten their blood glucose for the most part under control, but they can have episodes of hypoglycemia, and those episodes, they can become extremely serious if they're not prevented. Right? And we consider hypoglycemic in children as when symptoms occur when the blood glucose levels falls to about 60. Right? So a little bit different than the adult. So when it falls to about 60 or below, it can be because they've given too much insulin, right? Exercise has been excessive. They're not eating enough foods, so we're not getting enough carbohydrates, right? Symptoms that you typically see, there's nervousness, weakness, dizziness, sweating, tremors, right? But you got to remember too, in kids, besides those typical things that we're accustomed to seeing, sometimes some of the first signs are behavior problems, temper tantrums, stubbornness. They're just being unusually silly. Maybe they're really irritable. They're not really following instructions. They're just not acting themselves. So those might be the first signs before you get into the typical things that you see. Now, as the child gets a little bit older and can tell you, and they are able to pick up on these symptoms a little bit quicker, it makes it easier to identify it, and especially once they get used to kind of knowing what that feeling is like when they're hypoglycemic, right? But what if you've got a young child who can't tell you those things, a 2 or 3 year old? We really rely on the adult being able to pick up on behavior changes and other symptoms that might be occurring. Management, not any different than what you've talked about with like an adult. They need an immediate source of carbohydrate. So usually we start with a fast-acting carbohydrate, half a glass of orange juice, regular soda, right? Something that's got a lot of sugar, essentially the carbohydrate in it. Right? Easy for children to carry those glucose tablets or a hard candy like Lifesavers with them to give them that quick source of sugar if they would need it. If there's no improvement in their symptoms and their blood glucose has not risen by 15 after 15 minutes, then they need another carb. They need more carbohydrates. So again, we usually want a fast-acting carbohydrate. If, say, the child is comatose when they're first discovered, or too upset, or maybe they're too uncooperative, they're too out of it, they can't cooperate to take something orally, then parents can inject them with a particular amount of glucagon, IM, right? So it's not obviously something that we first jump to, and we typically think of giving them glucagon injection if they're completely like unconscious or out of it. However, you got to remember, if a child is too uncooperative and they're not getting enough glucose to the brain to be able to cooperate, then this may be something that we go to. But it's kind of typically like the last resort. If you can't get them to take something orally, then this is one of the things that we jump to. If for some odd reason the parent can't give a child an injection and oral sugar can't be given either, there are some other options that we can do. You do have to think about the risk for aspiration because we want to avoid that. We can use honey, corn syrup, cake icing gel, glucose. It can be rubbed into the gums or the cheek. Hopefully that'll bring them up just enough to where they're a little more cooperative that they can actually take something orally. You can also use corn syrup, and it can be given as an enema as well because it will absorb. And again, it's got high concentration of sugar that's going to increase their blood glucose. So as soon as they're out of the coma or they're much more cooperative and it's safe to give them something orally, then have them take a complex carbohydrate. So crackers, whole wheat toast is another good option as well. And of course, we need to monitor what their blood glucose would look like and taking the necessary steps to prevent hypoglycemia from occurring again. You have a nice comparison chart, came straight from your book, from table 48.5. That's a comparison of hypoglycemia versus hyperglycemia. Probably another good resource, something to look over. Probably not a lot of new information, but it would certainly be a good reminder for you. And part of our education to the parent and the patient, we certainly want to teach them about signs of ketoacidosis. What is ketoacidosis? Well, it's basically hyperglycemia, right? And if we've got hyperglycemia, if it gets too high, then we can get into the big complication, and the more serious one, diabetic ketoacidosis, or DKA. And I'll go into that a little more in depth in the next slide. But getting into ketoacidosis, diabetic ketoacidosis, it's considered a metabolic emergency. It is a serious complication of diabetes because the body produces very high levels of blood acids, which are called what? Called ketones, right? That condition, or the condition, develops when the body can't produce enough of its insulin, and it's going to find a source of energy somewhere, right? If we're not providing it and the body can't produce it, it's going to go find it elsewhere, and oftentimes it's going to break down fat as its fuel for energy. It can be very difficult for parents to distinguish between hypoglycemia and hyperglycemia because they do present with very similar symptoms. So if a parent's really unsure if they've got hypoglycemia or hyperglycemia, it's always better to just offer a child a carbohydrate. So treat them like they are hypoglycemic, because wouldn't you rather their blood glucose go up? It's already high. What's the difference if they're really hyperglycemic but you treat them like they're hypo? I'd rather their blood sugar go up because I don't want it to drop if they're already low. We'd have bigger issues, right? So in worst case scenario, if the parent's not sure, have them give them a carbohydrate, because the added carbohydrate's not going to do any harm if they're already hyperglycemic. Typically, if they have an inability to void when they're hypoglycemic, keep seeing all my spelling errors here for hypo. Usually with hyperglycemia, what happens? They've got polyuria, right? So the urine output is copious. With hypoglycemia, then they're too low, right? We're not putting out all this urine, so they have an inability to void. We want to assess blood glucose usually by finger stick, determine if they've got an AccuCheck type machine at home. Check to see if they're hypo or hyper, right? If we're in ketoacidosis and it's not being relieved when it first begins, and it's progressing, they can become more severe, and they will develop a particular type of respirations. Those respirations are usually very deep and they're rapid. And we call those, what do we call those? Call them Kussmaul's respirations, right? So with deep and rapid respirations, that equals Kussmaul's respirations, which is the body's attempt to blow off the carbon dioxide in order to lessen that acidotic state that we're getting into. Their breath is going to smell sweet. Why does it smell sweet? It's because of what? What's present? Ketones, right? Their pulse may be rapid. You might see signs of dehydration, right? Because again, if we're getting into DKA, we're going to start to see signs of dehydration, and dehydration is one of the things we see with DKA. They're going to have dry mucous membranes and skin, sunken eyeballs, no tears. Right? So we'll talk further, but we need to teach parents to recognize signs of ketoacidosis, because we certainly want to get that treated promptly before it becomes much more severe. All right, let's talk about the big complication, diabetic ketoacidosis, or DKA. You've talked about this with the adult. In all honesty, DKA is no different in the child than it is in the adult. Some of our numbers are a little bit different, but when you think about signs and symptoms and you think about treatment, it's no different than what you've learned in the adult, right? So diabetic ketoacidosis, or DKA, it's an insufficient insulin, right? Usually there's a failure, oftentimes why we get into DKA, failure to take the appropriate dose. We could also have acute stress, a trauma, poor management of the illness is often reasons why we get into DKA. So when we get into DKA, we have a progressive deterioration. All right, remember me talking about if you have the untreated child, a lot of these signs and symptoms you see in the untreated child are same things you see in DKA, right? So you have this progressive deterioration with dehydration, there's your blank, dehydration, electrolyte imbalance, acidosis, coma, and death if we don't have this recognized and get treatment, prompt treatment. So clinical manifestations you're going to see: polyuria, polydipsia. What happens to our urine output, at least initially, right? If we've got polyuria, polydipsia, it means we're going to have increased urinary output. So increased urinary output initially, but the problem is that's only going to last for so long. And then what happens to the cells and our urine output? Well, our urine output's then going to decrease because the cells are becoming dehydrated, right? So again, increased urine output initially, then it decreases as those cells become dehydrated. For a child for DKA, we consider their blood glucose level to be greater than or equal to 330. So that is different than the adult. So 330, greater than or equal to 330. They have signs of ketoacidosis, just talked about those. They have increasing restlessness. They probably have got some mental confusion or altered level of consciousness, or decreased level of consciousness, which can certainly lead into coma if we do not recognize this. How do we diagnose it? A lot of it is based on recognizing those signs and symptoms, those clinical manifestations early on. We are certainly going to look at what's their serum blood glucose level. We're going to do an arterial blood gas. Why would we need to do an arterial blood gas? Well, they're acidotic, right? We need to see where they're at. We need to do a serum electrolyte because they're losing other electrolytes, but we worry about specific electrolytes like the potassium is a big one, right? We want to monitor their BUN. They need an EKG. They need to have their urine tested, especially tested for ketones and glucose. We're going to test their CBC because probably what's going to be elevated? White blood cell count. May or may not have an infection present. Remember we talked about white blood cell count can be elevated even when there's no infection present. So those are all diagnostic pieces that we look at. Treatment-wise, we want to recognize this early. That's why it's so important to teach parents, really patient and parent, to recognize those signs and symptoms early. And of course, good management to avoid getting into decay. But sometimes it can't be avoided just from traumas or stress. right? But we want to recognize it early because we need to start treatment as soon as possible. And typically, if they come into the ER and they are identified as being in DKA, the treatment can be started in the ED, but eventually they're going to be admitted to the ICU. So therapy is usually instituted in one of two settings, the ICU or the ED. At some point in time, we're going to put them on a cardiac monitor probably early on. Again, we're going to watch because we're worried about if there's a low potassium level, how that's affecting the heart. They're going to need IV access. And when we get IV access and we start trying to get the DKA under control and treat it, one of the big things, the first thing we need to do is we need to give them a hydration bolus. And we're going to do that with 0.9% normal saline. We're going to give them a bolus of normal saline. And really what that's aimed at is to start correcting the dehydration that's present. Because we have to correct the dehydration before we can start correcting it. It may not be fully corrected, but we want to start correcting that, because if those cells are so dehydrated, we can't give them the insulin, right? So they need insulin, but that's not the first thing you're going to do. When you think about priority, it's get them an IV access, get them the normal saline bolus to start correcting that hydration, plump those cells back up, and start to get them rehydrated. Hydration it's going to take hours depending on how severe they are. Once we've started to correct their dehydration, then we're going to institute or start to bring in giving them insulin administration. But you've got to give them the hydration first, and then we're going to add in a continuous insulin. Part of that is because, one, you need to know what their serum blood glucose level is, and after their initial rehydration bolus. And again, they may not be completely rehydrated, but if you don't hydrate them first, the insulin's not going to do any good, right? Because the cells are too dehydrated. The cells wouldn't be able to take up the insulin if you tried to start with insulin first. Right? So what kind of insulin are we going to give them? They need continuous IV insulin. They need continuous IV regular insulin. Don't worry about the dosage so much. They just need regular insulin, right? And then we start thinking about the evaluation and the correction of the electrolyte imbalance that's going to be present as well. So correction of the electrolyte imbalance. We want to correct their acidosis. And remember, I already talked about we need to monitor for hypokalemia, especially once fluids balance has been restored. We're worried about the potassium level. Oftentimes they are low, which is why they need to be on a cardiac monitor, because we're worried about their cardiac status. And if they would need potassium replacement, we never give potassium as a bolus or push it. That is something that is given as a infusion, and closely monitoring them. The other big thing is you would never start potassium replacement until you know, one, what their serum potassium level is, and to know if is it normal or low, and you need to make sure that they're voiding, because remember, their urine output's going to drop off. So after a while, right? So you need to make sure the kidneys are functioning and that there's not enough damage that's been done. So not only knowing the various labs when it comes to kidney function, so looking at your BUN, right? That's going to tell us kidney function. But one of the easiest ways to know if kidneys are functioning properly, are they voiding? Right? If they're voiding, kidneys are functioning, at least somewhat, right? So we would never institute or start potassium until we know our potassium level, and if it's low, then making sure that they are able to void and they've had urinary output, right? So again, we've already talked about monitor for hypokalemia, monitor for renal function, evaluate the cardiac status, have them on a cardiac monitor, especially even before you do potassium, but even when you are giving a potassium replacement, if it's needed, they need to be on a cardiac monitor as well. And really, your nursing care is all the same things we just talked about. It's just kind of listing them out a little bit differently. Obviously, part of that is also looking at level of consciousness, any other neurological signs. Lots of family support and education and information. And and all the other things, medical things that we need to be doing. You can't forget about educating the family. All right, type 2 diabetes. Why would I be talking about type 2 diabetes? Who typically gets type 2? Well, it's usually after the age of 40. Okay, well, if it's after the age of 40, that's the adult. It's not the pediatric. Why are we talking about it? Well, we talk about it because what we talk about in growth and development related to weight. We're seeing more and more kids who are obese, right, and overweight. So unfortunately, with that being said, we're seeing type 2 diabetes sometimes occur younger and younger. So the information here, for the most part, not any different than what you do with the adult. Think about your management. What's the difference between type 1 and type 2? They don't eat insulin, right? That's not their problem. It is managed with diet, and with, if it's not just diet alone, then it's diet and oral hypoglycemic agents. Typically, the big one that you most often think about is metformin, or the brand name is metformin, right? So again, diet and exercise, oral anti-glycemic agents like metformin can help, and that'll decrease the amount of glucose that's produced by the liver, increases the insulin sensitivity in the liver and the muscle cells. The rest of that you can go through on your own. The complications, again, teaching about preventing complications overall as well, and the signs and symptoms that you'll see. All right, the last disorder we're going to talk about is actually a metabolic disorder, and it's called phenylketonuria, or PKU. Much easier to say, right? So it's a disease of the metabolism, and it's an inherited autosomal recessive trait. Autosomal recessive trait. The pathophysiology, basically the infant's lacking a particular liver enzyme, the phenylalanine, which then causes excessive buildup of the phenylalanine. That's how you say it, sorry, phenylalanine. It causes it to build up in the bloodstream and the tissues, which can lead to permanent brain tissue damage and lead to severely cognitively challenged child. And part of it too is the metabolite of the phenylpyruvic acid, which is what breaks down your phenylalanine, spills into the urine. It causes the urine in the body to have this musty or mousy odor. Right? So their symptoms. The urine or the body has a musty or mousy odor. They have blue eyes, very fair skin. They look very pale. Sometimes the skin almost looks translucent at times. Very light blonde hair. And that's because they're missing the tyrosine that's necessary for building body pigment and the thyroxine. They will have growth failure because of the inadequate thyroxine. They can have seizure disorders because of the buildup of the phenylalanine into the bloodstream. Their skin is much more prone to eczema or atopic dermatitis, which is what we're going to talk about in the integumentary. So there is a strong association between a child who has PKU and having eczema. And that doesn't necessarily mean that they will have it, or if the PKU has not been diagnosed and they have eczema, they do need to be rescreened, especially in a young infant. So all infants who have atopic dermatitis need to be rescreened for PKU because of the strong correlation. They will have microcephaly, which is just smaller head. They have frequent vomiting, and their irritability. What I didn't tell you is there's right at the top of my little pictorial here, there's one that says PKU education. There's a patient education link. If you click on it, it'll take you right to the website. And normally what I would play in class, it kind of just gives you a little bit more about the autosomal recessive and how it occurs, and gets into a lot of this that we are covering. But it does it in a much more patient-friendly type manner, because that's where it was developed for a patient or family. So might want to look at that as well. And then I'll talk further about screening and therapeutic management of PKU on the next part. Okay, In order to screen for PKU, we do screen all infants as part of that newborn screening with a blood spot analysis, but it needs to be done after the infant has received 2 full days of breast or formula feeding. If you did click on or do click on that PKU education link that I have, they talk about after 24 hours. Our book and what I want you to know is 2 full days of breast or formula feeding. They need to have enough intake of breast milk or formula in order to really determine whether PKU is present. PKU cannot be detected by amniocentesis, and that's because the PKU levels don't rise in utero while the infant is under the mother's enzyme system. What they can do is they can do recombinant DNA techniques that's used for carrier detection during prenatal or for prenatal diagnosis, and they can do that through the maternal serum. Right? When we talk about therapeutic management, they need dietary restrictions for lifetime. Formula, they need a special formula that's very low in the phenylalanine, because the phenylalanine is what they can't break down. So one example is Lofenac is a low phenylalanine formula. It does cause the stool to be loose. It does have a disagreeable taste, but it is something that eventually they do get used to it. If there's a mom who's really had her heart set and wants to breastfeed, they may be able to still breastfeed, but it's very limited. It's not exclusive breastfeeding, and that's again because they're getting the phenylalanine through the breast milk, and then they're not able to break that down, so then it builds up. So it depends on what the infant's levels of phenylalanine are as to how much mom can breastfeed or how frequently she can breastfeed. Oftentimes difficult as the child grows to maintain those dietary restrictions for lifetime because natural protein, there is no natural protein that has both low phenylalanine concentration and normal levels of the other amino acids, which are important for growth. So it's really a balancing act between getting enough nutrition to support growth and development, but not consuming too much protein that increases the blood phenylalanine levels. Foods that are highest in phenylalanine are rich in protein, so your meats, eggs, milk. Foods that are lower in phenylalanine, orange juice, bananas, potatoes, lettuce, spinach, peas, a special formula, the low phenolac formula, can be used to prepare different, treats like ice cream, cake, or milkshakes, pudding, things like that that would typically call for eggs and milk products. We can certainly use that as a substitute. When you think about diagnostic monitoring, they do need ongoing monitoring. They do need blood and urine phenylalanine levels monitored frequently, especially in the beginning, but even throughout, because we want to keep them below 8. Not that I'm going to ask about that number, but we want to keep and make sure that the phenylalanine levels are staying low and not getting too high. Their hemoglobin levels need to be monitored, and we're looking for anemia. Well, why would we be looking for anemia? Again, remember, what's in a lot of these, where do we typically get our good iron levels? Those are in those protein-rich foods. Well, they can't have them, right? So anemia certainly can become an issue for these kids, so important to monitor. We want to screen for obesity at well-child visits as well, because the foods that they're allowed to have tend to be high in carbohydrates and replaces protein. Right, your nursing considerations. Again, the dietary restrictions, a lot of education. They'll need consultation with a dietitian early on and maybe sometimes throughout in order to maintain those dietary restrictions for lifetime. We need to monitor their phenylalanine levels, offering parental child support, certainly giving that opportunity to express their feelings. It can be difficult, especially in the beginning, with a young child who's on such a restricted diet. Because think about what you learn back in growth and development. Young children often, they're picky eaters, they don't like a whole lot, or they get very stuck on certain foods. Well, they don't have much variety if they're a picky eater. And of course, think about too, as they get older, especially, older school age and adolescence, sometimes they get sick of these restrictions that they're under, and they're like, what harm can really happen? And they sometimes go off their diet, or they just get sick of always having to follow the special diet. So it has its challenges throughout the various ages, but it is important to make sure we are supporting them. Another thing to think about too, to touch on, is if a woman who has PKU anticipates that she wants children or wants other children, she needs to anticipate what exposure the fetus has to high levels of phenylalanine during pregnancy, and the risk associated with that in the child being born with cognitive challenges. Again, if you look at that PKU education, it goes a little bit more in depth about even a woman who, say it's a child, she was diagnosed as an infant with PKU, and maybe she went off her diet or for whatever reason. If she's planning to become pregnant, or tries to become pregnant, or does become pregnant, especially even before she becomes pregnant, she needs to get back on that special diet of the low phenylalanine, the low protein diet, because we don't want problems for the fetus as well, who could be exposed to those high levels. So I really recommend looking at that PKU education link. That's what I would have used in lecture, primarily to lecture the PKU content, and then gone back and filled in your blanks, because I think it does a nice job of giving you this good overview of PKU. So check it out.